Welcome to the deep dive. Today, we're tackling a crucial set of source materials, basically giving you the complete playbook for understanding the vascular system.
Yeah, if you need to really get a handle on perfusion and clotting concepts, those twin pillars of circulation, this is definitely for you.
We're aiming to make this your shortcut. Our goal isn't just, summarizing. We want to give you that clinical context, the specific, high-stakes teaching points you absolutely need to know.
That's right. We're navigating the body's complex plumbing system. We'll be looking at conditions like hypertension, atherosclerosis, peripheral arterial disease, and venous thromboembolism.
And for each one, we'll break down the mechanism, the key diagnostic steps.
And most importantly, the critical nursing interventions and those really vital medication teaching priorities. Think of it as a fast track to getting comfortable with vascular care.
Okay, before we jump into the specific diseases, let's quickly set the stage with some key terms. We need to be clear on the difference between arterial and venous problems right from the start.
Good idea. So on the arterial side, we're often talking about the vessel structure itself. Simple age-related stiffening and hardening of the artery walls. That's arteriosclerosis.
That's hardening with age.
Right. But the actual disease process, the one that causes most heart attacks and strokes that build up of fatty plaques inside the artery lining, that's atherosclerosis. Big difference.
Got it. Atherosclerosis is the plaque. That's the root of the perfusion problem we'll discuss.
Exactly. Then switching over to the venous side, the focus really shifts to clotting.
Right.
The big umbrella term for clots forming in the deep veins is venous thromboembolism, or VTE.
And that covers both DVT and PE.
Precisely. It includes deep vein thrombosis,
Yeah.
DVT, usually down in the legs, and the really dangerous complication, pulmonary embolism, PE, if that clot travels.
Okay, one last foundation piece. The different types of ulcers, arterial versus venous.
Yeah, crucial distinction. Arterial ulcers are caused by ischemia, lack of blood flow. So they tend to be painful, look sort of punched out, and often appear on toes or pressure points, dry wounds usually.
Okay, painful and dry.
And then venous stasis ulcers. They result from chronic blood pooling, that high venous pressure. They're usually found on the inner ankle, the malleolus, and tend to be wetter, maybe less acutely painful than arterial ones.
So wet and often around the ankle. Got it. That distinction, painful dry versus wetless painful, that's a key takeaway right there.
Definitely.
All right, let's start with hypertension, our main example for a perfusion issue. It gets called the silent killer because, well, that chronic high pressure puts a huge strain on the whole circulatory system.
It really does.
Before we get into stages and meds, can we quickly touch on how the body normally keeps blood pressure, or BP, stable? What are the main controls?
Sure. Fundamentally, BP is just cardiac output, how much blood the heart pumps times total peripheral vascular resistance, or PVR, how constricted the vessels are.
CO times PVR.
Right. And the body has these really sensitive systems to manage that. First up is the arterial baroreceptor system. Think of them as pressure sensors in the big arteries, like the carotids and aorta.
They're constantly checking the pressure.
Constantly. If pressure drops, boom. They trigger the sympathetic nervous system to constrict vessels and speed up the heart rate to bring BP back up.
And if the pressure's too high, or maybe there's just too much fluid volume, that's where the kidneys come in, right?
Exactly. The kidneys are key for regulation of body fluid volume. If you retain too much sodium in water, volume goes up, pressure goes up. So the kidneys work to excrete that extra fluid diuresis. Less volume means lower CO and thus lower BP.
Simple volume control.
Yep. Then we have the system everyone talks about because so many meds target it. The renin-angiotensin-aldosterone system, or RAA.
Ah, yes, RAS. Always comes up.
It's basically the body's emergency boost pressure and volume system. If the kidneys sense low blood flow, maybe you're dehydrated or your pressure's dropped, they release renin.
Okay.
Renin kicks off this whole cascade that eventually produces angiotensin II. And angiotensin II is a really potent vasoconstrictor. It clamps down blood vessels everywhere.
Raises the PVR part of the equation.
Right. Plus, angiotensin II tells the adrenal glands to release aldosterone. Aldosterone then tells the kidneys, hold on to sodium and water.
So vasoconstriction and more volume?
Double whammy.
Exactly. Drives BP up significantly. It's vital for survival in short bursts, but if it stays chronically active, that's a major driver of hypertension.
Makes sense. And the last one.
Vascular autoregulation. This is more of a local thing. It lets individual tissues, like your brain or kidneys, adjust their own blood flow to stay constant, even if your overall BP is fluctuating a bit. But with chronic hypertension, even this can get overwhelmed, leading to organ damage.
Which brings us to why classifying BP is so important. It tells us when we need to act.
Absolutely. The four standard categories really guide treatment decisions. Can you run through those cutoffs again? It's crucial for everyone to have these memorized.
Okay, let's lock these in. Normal is less than 120 systolic A&D, less than 80 diastolic. Easy enough.
Right.
Then things start creeping up into elevated. Systolic 120 to 129, but the diastolic is still below 80.
Still below 80, yeah. The real diagnosis starts with stage 1 hypertension. That's 130 to 139 systolic, or R 80 to 89 diastolic. Notice the or, either number hitting that range, counts.
That's the point.
And finally, stage 2 hypertension is anything 140 or higher systolic, or R 90 or higher diastolic.
And generally, that move from elevated to stage 1 is where we seriously start thinking about medications, not just lifestyle changes.
We also need to think about why someone has high BP. Most cases are primary hypertension, right? No single clear cause.
Correct. Primary or essential hypertension is the most common. It's usually a mix of genetics, lifestyle, diet, weight, activity level, and just aging.
But sometimes there's a specific cause. That's secondary hypertension. What kind of underlying issues should make us think secondary?
Yeah, secondary hypertension is like a clue pointing to something else. The sources really emphasize looking for chronic kidney disease makes sense if kidneys can't manage volume.
Right.
Also, endocrine problems like Cushing syndrome or rare tumors like pheochromocytoma that pump out adrenaline-like hormones. And importantly, certain drugs can cause it, particularly estrogen-containing birth control pills and glucocorticoids, like prednisone.
So if you find secondary hypertension, treating the underlying cause is key. Like if it's renal artery stenosis, maybe fixing that.
Exactly. Treat the kidney disease, stop the offending drug if possible. That's the primary approach.
Now, for assessment, we know we should check BP in both arms, but you mentioned orthostatic hypotension earlier, checking for that drop when standing up. Why is that such a priority?
It's a huge safety issue, especially for older adults or anyone starting BP meds, particularly diuretics. Orthostatic hypotension is that significant drop, 20 points systolic or 10 points diastolic, when going from lying down to standing up.
And the risk is?
Dizziness, lightheadedness, falls. Confusion even. So a major fall risk, so we have to check it, especially when initiating or changing therapy.
Makes sense. Beyond just the BP numbers, what else can a physical exam tell us about how severe or maybe what's causing the hypertension?
A couple of key things. A provider doing a fundoscopic exam, looking into the back of the eye, can literally see damage to the tiny blood vessels in the retina. Those changes directly show how much wear and tear the high pressure is causing systemically.
Wow, the eyes are a window to the vessels.
They really are. Also, listening to the abdomen if you hear abdominal bruits, that swishing sound, that could suggest renal artery stenosis, pointing back to a secondary cause.
Okay, let's pivot from the chronic picture to the acute emergency, the hypertensive crisis. This is when things go sideways fast and the patient is symptomatic and in danger.
Right. A hypertensive crisis isn't just high BP. It's severe elevation. Think over 180, 120 that's rapidly progressing and causing acute target organ damage. Kidney failure, stroke, heart failure right now. It's a true medical emergency.
What are those immediate critical signs and symptoms that someone needs to recognize right away?
They're often pretty dramatic. A really severe headache, often described as crushing. Dizziness, sudden blurred vision, maybe extreme anxiety. You might also see epistaxis, nosebleeds, shortness of breath, dyspnea, and sometimes even chest pain, indicating the heart's under strain.
All right, so if you encounter a patient with those symptoms and a BP like 121/25, what's the immediate step-by-step game plan?
Okay, priority sequence. First, get them comfortable and safe. Position them in semi-Fowlers, helps with breathing and maybe pressure on the brain.
Good.
Next, optimize oxygenation. Administer oxygen, usually via nasal cannula, as ordered.
Okay, position, oxygen, then meds.
Then meds. You'll be administering an IV antihypertensive drug like nitroprusside or labetalol, usually through an infusion pump for precise control. Titrating carefully based on the BP response.
And the monitoring during this period is intense.
Absolutely meticulous. You need to monitor BP every 5 to 15 minutes. The goal is to bring the pressure down, but gradually. You watch until the diastolic pressure is below 90,
Okay.
but critically not less than 75. You don't want to crash their pressure. Once it's stabilizing below 90, you can maybe stretch the checks to every 30 minutes.
And that gradual reduction is key. What's the rule there?
The absolute safety rule is no more than a 25% reduction in mean arterial pressure within the first hour. Dropping it too fast can actually cause a stroke or kidney failure by suddenly cutting off perfusion to organs that were used to that high pressure.
Wow. So bringing it down too quickly is just as dangerous.
Exactly. It's a very careful balancing act. And the final step is just constant vigilance. Keep observing for any neurologic changes, seizures, numbness, weakness, or cardiovascular issues like dysrhythmias. That whole sequence is vital.
Okay, having covered the crisis, let's focus on the long-term daily management, the antihypertensive medications. This is where patient teaching is absolutely paramount for safety. Let's go through the main classes, hitting those must-know points, starting with diuretics, the volume reducers.
Right, diuretics are often the first step.
Mm-hmm.
You've got thiazides like HCTZ or chlorthalidone, often first line for uncomplicated cases. Then the more potent loop diuretics like furosemide, Lasix, and finally the potassium-sparing ones like spironolactone.
Okay, and the big safety concern with thiazides and loops is electrolytes, isn't it? Specifically, losing potassium hypokalemia.
Yes, that's number one. Low potassium can cause weakness, dizziness, leg cramps, and worst case, serious cardiac dysrhythmias.
Was the teaching?
Priority teaching is emphasizing regular lab checks for potassium, teaching the signs of low K+, like muscle weakness, and encouraging foods high in potassium, bananas, oranges, potatoes, spinach to help replace what's lost.
Makes sense. Conversely, with the potassium-sparing diuretics like spironolactone, the risk flips.
Rotally flips. Now you worry about hyperkalemia, high potassium, so you monitor for things like irregular pulse, muscle weakness, or spasms, again, maybe tingling.
And the teaching changes completely.
Dramatically. Patients on these need to avoid potassium supplements and those salt substitutes, which are often loaded with potassium chloride. Very different advice.
Got it. Any special alerts for specific patient groups with diuretics?
Two key ones mentioned. Thiazides need caution in patients with diabetes. They can mess with blood sugar control, potentially making hyperglycemia worse.
Okay.
And also caution in patients with gout, as thiazides can sometimes raise uric acid levels.
And thinking about older adults, that orthostatic hypotension risk.
Yes, loop diuretics especially are often avoided in older adults if possible. Their potent, quick action really ups the risk of dehydration and those dangerous falls from orthostatic hypotension.
So, a simple but really important piece of teaching for all diuretics.
Take them in the morning. Avoids nocturia, having to get up multiple times at night to pee, which directly reduces fall risk, especially in the elderly.
Yeah,
Simple but effective.
great tip. Okay, moving on to beta blockers, BBs. The OL drugs, metoprolol, canolol, these control heart rate and contractility.
Right, and the absolute clinical safety priority here is checking vitals before giving the drug.
Every single time.
Every single time. Beta blockers slow the heart rate and lower BP. So before giving any dose, check the apical pulse and the blood pressure. You need to memorize the hold parameters. Hold the dose if the heart rate is less than 50-60 beats per minute OR, if the systolic BP is less than 90-100 millimeter Hg, and obviously notify the provider.
Okay, less than 50-60 HR, or less than 90-100 systolic. Got it. Now, I remember reading they pose a specific danger for people with diabetes. Why is that?
This is a really critical teaching point.
Yeah.
So when someone with diabetes becomes hypoglycemic, their blood sugar drops too low. Their body usually reacts with a sympathetic response. Tachycardia, fast heart rate, sweating, feeling shaky, those are the warning signs.
Right, the body's alarm system.
Exactly. But beta blockers block that sympathetic response. They can mask the tachycardia. So the patient doesn't get that early warning sign that their sugar is dangerously low. They might not realize it until it's much more severe. Huge safety issue.
Wow, okay. That's vital to teach. And the other big warning for BBs, sudden stopping.
Yes. Patients absolutely must not stop these drugs abruptly. If they do, they risk severe rebound hypertension, angina, or even a heart attack. The body gets used to the beta blockade, and suddenly removing it causes a massive sympathetic surge.
So how should they stop if needed?
It needs to be tapered off slowly, usually over about 2 weeks, under medical supervision. Never just quit cold turkey.
Got it. Okay, next big class. The drugs hitting that RAS system we talked about, ACE inhibitors, the prils like lisinopril and allopril, and ARBs, the sartans like valsartan and oleucers.
Yeah, these are workhorses for hypertension and heart failure. ACE inhibitors stop the enzyme that makes angiotensin II, and ARBs block where angiotensin II tries to attach. Both lead to vasodilation and lower BP.
Let's focus on ACE inhibitors first. They have that classic side effect.
The cough, that persistent, dry, nagging cough. It happens because ACE inhibitors also prevent the breakdown of a substance called bradykinin. Bradykinin builds up and irritates the airways.
So what do you tell the patient?
Tell them to report that cough immediately if it develops. It's not dangerous, but it's annoying enough that people stop taking the drug. If it happens, they'll likely be switched to an ARB, which doesn't cause the cough.
Okay. And for both ACs and NRBs, what are the serious risks to monitor for?
We watch for hyperkalemia, high potassium again, maybe a bit more with ARBs. But the really scary, though rare, one is angioedema.
Angioedema, explain that.
It's rapid swelling, usually of the face, lips, tongue, throat. It can obstruct the airway. It's a potentially life-threatening allergic reaction. Patients need to know to seek emergency help immediately if this happens. Critical teaching.
Definitely. And anything special about the first dose of an ACE inhibitor?
Yes, the first dose can sometimes cause a more pronounced drop in blood pressure. So the key instruction is, get out of bed slowly, change positions gradually, report any significant dizziness. While the risk might be less than older drugs, a big drop, like more than 20 points systolic, needs to be reported.
Good practical advice.
Okay.
Last major class here, calcium channel blockers, CCBs, verapamil, amlodipine, diltiazem.
CCBs work by blocking calcium from entering smooth muscle cells and blood vessels, causing them to relax vasodilation. Some also slow the heart rate.
So like beta blockers, check vitals first.
Yes, definitely monitor pulse and BP before giving, especially with ones like verapamil and diltiazem that affect heart rate and AV conduction more directly.
And the absolute must-know, never forget teaching point for CCBs, the interaction.
Oh yeah, this one's huge. Patients absolutely must avoid grapefruit and grapefruit juice.
Why? What does grapefruit do?
We need to explain the why. Grapefruit contains compounds that basically shut down a specific enzyme in the gut and liver, CYP3A4, which is responsible for breaking down, metabolizing many CCBs.
So if the enzyme's blocked?
The drug doesn't get broken down properly. Levels in the blood can soar to toxic levels, dramatically increasing the risk of side effects like severe low blood pressure or other toxic effects. This isn't a mild interaction. It can be really dangerous. The teaching has to be crystal clear. Avoid grapefruit.
All right, let's shift gears from controlling overall pressure to dealing with problems caused by plaque buildup in specific arteries.
Okay.
Atherosclerosis and its major consequence in the limbs, peripheral arterial disease or PAD.
Right. Atherosclerosis is really the foundation for a lot of cardiovascular disease.
Yeah.
It's fundamentally an inflammatory process. It starts with some kind of injury to the endothelium, that inner lining of the artery.
Damage to the lining.
Yeah. That damage triggers inflammation, attracts immune cells, cholesterol gets deposited, and eventually you get these fatty streaks that grow into fibrous plaques. These plaques narrow the artery, harden it, and reduce blood flow.
And a huge driver of this is hyperlipidemia, right? High cholesterol and triglycerides.
Absolutely. Elevated LDL-C, the bad cholesterol and high triglycerides, TGs, are a major fuel for this plaque-building fire.
So interventions logically focus on slowing that down. Diet is key.
Definitely. The sources emphasize a diet rich in vegetables, fruits, whole grains, low-fat dairy, lean protein, basically a heart-healthy pattern,
Yeah.
and crucially, limiting saturated and trans fats. The target mentioned is getting less than 6% of your daily calories from saturated fat.
That's pretty specific. And exercise.
Also critical, not just for weight, but it directly impacts lipid levels too. Aim for aerobic activity 3 to 4 times a week for about 40 minutes each session. Consistent effort makes a difference. Lifestyle really is the first line here.
Okay, so when this atherosclerosis happens specifically in the arteries of the legs and feet, we call it peripheral arterial disease, PAD. It obstructs flow, leading to ischemia.
Right. Often called letter lower extremity arterial disease.
Right.
And to help understand how bad it is, we often talk about 4 clinical stages of ischemia. These are great for you to memorize.
Let's break them down. Stage 1.
Asymptomatic. The patient doesn't feel anything wrong, but if you examine them, you might find weakened or absent pedal pulses, or maybe hear a faint bruit, a swishing sound over an artery like the femoral. The disease is there, just silent.
Okay. Then stage 2.
Claudication. This is the classic symptom everyone learns. It's muscle pain, cramping, or burning, usually in the calf, but could be thigh or buttock that comes on with exercise.
Like walking.
Exactly. And the key is it's reliably relieved by rest. Walk a certain distance, pain starts. Stop walking, pain goes away. Very predictable pattern.
Got it. Stage 3 sounds worse.
It is. Breast pain. This signifies much more severe ischemia. Now, the pain happens even when the patient is at rest, often waking them up at night. It's typically in the foot or toes.
And there's a trick to relieving it.
Yeah, a key clinical clue. The pain is often relieved by putting the leg in a dependent position, like hanging it over the side of the bed. Gravity gives that little bit of extra help to get blood down there. That dependence relieving pain is a hallmark of rest pain.
Okay, dependent position for relief. And the final stage, stage 4.
Necrosis gangrene. This is end stage. Tissue damage is irreversible. This is the ulcers, blackened tissue, sometimes that distinct smell of gangrene. Limb loss is a real threat here.
Now, sometimes the blockage isn't gradual, it's sudden, right?
Yeah.
An acute arterial occlusion, that's an emergency.
Huge emergency, usually caused by an embolus, a clot that traveled from somewhere else. The onset is dramatic, and we use the 6 Ps of ischemia to assess this rapidly. You need to know these cold.
Let's list them out. Pain.
Severe sudden pain.
Pallor.
The limb looks pale, white, waxy.
Pulseless.
No pulse distal to the blockage. Critical sign.
Paresthesia.
Numbness, tingling, like
Yeah.
pins and needles.
Paralysis.
Inability to move the limb,
And poikilothermy.
meaning it feels cold compared to the other limb. Coolness.
Okay, pain, pallor, pulselessness, paresthesia, paralysis, poikilothermy. Why are paresthesia and paralysis particularly alarming signs?
Because they mean the nerves are dying from lack of oxygen. Paresthesia, that numbness and tingling, means the nerve is screaming for oxygen. Paralysis means the nerve damage is likely severe, maybe even permanent. Once paralysis sets in, the clock is ticking incredibly fast to save the limb, if it's even possible. Needs immediate surgery.
Okay, terrifying. For diagnosing the chronic PAD, not the acute kind, what's the go-to test?
The ankle brachial index, ABI. It's simple, non-invasive. You compare the systolic blood pressure measured at the ankle with the systolic pressure measured in the arm.
And the magic number.
It's a ratio. Normal is around 1.0 or slightly higher. The key diagnostic number to memorize is an ABI less than 0.90. That confirms PA. The lower the ABI, the worse the disease. Like 0.5 would be severe PA.
Less than 0.90. Got it. And just by looking at the leg in severe PAD, what might you see?
It'll likely be cold to touch. When you lift the leg up, elevation, it might turn really pale, almost gray or bluish, cyanotic. Then when you hang it down, dependent position, you often see that dependent rubor, a dusky, reddish, maybe mottled color as the blood struggles to pull back in.
Interesting visual cues. Okay, let's talk interventions for chronic PA. Non-surgical stuff. Exercise helps, but how exactly?
Yeah, the advice is specific. Encourage the patient to walk until they feel the claudication pain, then stop and rest until it goes away, and then try to walk a little farther.
Pushing through it slightly.
Kind of. This walk-rest-walk cycle helps encourage the body to develop collateral circulation, tiny new blood vessels that bypass the main blockage. It's like building natural detours.
Clever. And temperature. Warmth helps vasodilation, but there's a big warning.
Right. Keep the patient's environment warm. Suggest warm socks, insulated shoes, good things. But T, and this is a huge nursing safety priority, do not apply direct heat to the affected limb. No heating pads, no hot water bottles.
Why not?
Because the ischemia often causes decreased sensation. They can't feel how hot it is, and they can get severely burned very easily, adding injury on top of injury. Massive risk.
Okay, no direct heat. What else should they avoid?
Avoid anything that constricts flow further. Don't cross legs at the ankles or knees. Avoid tight clothing, garters, socks with tight elastic tops. Keep everything loose.
Makes sense. Meds for PAD mainly involve statins for the cholesterol.
Yep, we'll dive into those next.
And antiplatelet agents like aspirin or clopidogrel, Plavix, to prevent clots forming on those narrowed, rough plaque surfaces.
Right, reduce the risk of MI or stroke.
Yeah.
There's also one drug mentioned specifically for the claudication symptom itself, silestazol.
What does that do?
It's a phosphodiesterase inhibitor. Its main job is to help improve walking distance in people with really disabling intermittent claudication. It doesn't fix the blockage, but it can make activity more tolerable. Patients should know it can cause headaches or GI upset, though.
Okay, let's really focus on statins. These are absolutely central to managing atherosclerosis and preventing PAD progression. The atorvastatins, simvastatins, the acvastatins, the safety teaching here is critical.
They really are cornerstone drugs, super effective. They work by blocking an enzyme in the liver called HMG-CoA reductase. This enzyme is essential for making cholesterol.
So block the enzyme.
You block cholesterol production in the liver. This forces the liver to pull more LDL-C, that bad cholesterol, out of the bloodstream to use, effectively clearing it from circulation. Lowers LDL significantly.
Okay, very effective. But they come with potential side effects. What are the 2 big warnings patients must report?
Muscle problems and liver issues. Patients need to report any unexplained muscle aches, soreness, tenderness, or weakness. This is crucial.
Why is muscle pain such a red flag?
It can range from mild myalgia to a much more serious condition called rhabdomyolysis.
Rhabdo. That sounds bad.
It is. Rhabdomyolysis is the rapid breakdown of skeletal muscle tissue. This releases muscle proteins, particularly myoglobin, into the blood.
And that's dangerous because,
Myoglobin is toxic to the kidneys. It can clog them up and lead to acute kidney failure. It's rare, but potentially fatal. So unexplained muscle pain, especially if combined with dark, tea-colored urine, needs immediate medical evaluation. Cannot ignore muscle symptoms on a statin.
okay, muscle pain report immediately, and the liver.
Because statins work in the liver, they can sometimes cause an elevation in liver enzymes.
Yeah.
So periodic liver function tests, LFTs, are needed to monitor this. If enzymes get too high, the dose might need adjusting or the drug stopped. They're also generally contraindicated in active liver disease and definitely during pregnancy.
Got it. Now, the interaction everyone needs to know. Grapefruit, again.
Yes. Just like with some CCBs, the warning here is absolute. Patients must strictly limit or completely avoid grapefruit and grapefruit juice.
Let's reinforce the why one more time.
Grapefruit contains substances that inhibit that same CYP3A4 enzyme in the gut and liver. This enzyme is responsible for metabolizing many statins. If the enzyme is inhibited,
The statin doesn't get broken down.
right, drug levels in the body can skyrocket, essentially creating an overdose effect.
And the consequence of that overdose with statins.
A massively increased risk of those toxic side effects, especially the severe muscle injury and rhabdomyolysis we just talked about. It dramatically raises the danger profile. Even one glass of grapefruit juice can significantly boost levels of some statins.
So the teaching needs to be uncompromising.
Absolutely. For some statins, the advice is total avoidance. For others, maybe no more than half a grapefruit or 8 ounces of juice daily. But honestly, complete avoidance is often the safest message. Protecting the muscles and kidneys is paramount here.
Okay, big shift now. We're moving completely over to the venous side of things. The main threat here isn't lack of flow to tissues, it's inappropriate clotting within the veins, venous thromboembolism, or VTE.
Exactly. VTE includes both deep vein thrombosis, DVT, the clot in the deep vein, usually the leg.
And pulmonary embolism, PE, if that clot breaks loose and travels to the lungs, which can be fatal.
Absolutely.
Yeah.
And the why behind VTE formation is beautifully summarized by Virchow's triad. It's a classic memorization tool because it outlines the 3 main factors that promote clot formation. If you understand these, you understand the risk factors.
Okay, let's break down the triad. Factor 1.
Stasis of blood flow. Basically, blood that isn't moving well tends to clot. Think prolonged immobility, bed rest after surgery, long car or plane rides, paralysis. Blood just pools in the veins.
Okay, stasis. Factor 2.
Endothelial injury. This means damage to the inner lining of the blood vessel wall. Surgery, trauma, inserting a central venous catheter, anything that roughens up that smooth lining creates a spot where platelets can stick and start a clot.
Makes sense. Injury attracts clots. And the third factor. This explains why some people are just more prone to clotting.
That's hypercoagulability, an increased tendency of the blood itself to clot. This can be inherited genetic conditions or acquired. Things like certain cancers, severe infection or sepsis, dehydration, pregnancy, and again, those estrogen-containing oral contraceptives can all make the blood stickier.
So stasis, injury, hypercoagulability, if you have elements of these, especially combined, your VTE risk goes way up.
Precisely. That's why we assess for these risks in hospitalized patients, for example.
Now, if someone does develop a DVT, what are the classic signs and symptoms we need to be alert for?
The most common signs are calf or groin tenderness or pain, and really key, the sudden onset of unilateral swelling of the leg. One leg suddenly gets bigger than the other. That asymmetry is a huge red flag.
Unilateral swelling. Got it. What about Hohenstein? Pain with foot dorsiflexion.
Yeah, the sources specifically say Hohenstein is not reliable and actually isn't recommended anymore. It's not sensitive, not specific, and there's that theoretical, maybe small, risk of dislodging the clot by manipulating the foot. So focus on the tenderness and unilateral swelling.
Good to know. For diagnosis, if you suspect a DVT, what's the best test?
The preferred test, the gold standard really, is venous duplex ultrasonography. It's non-invasive, uses sound waves. It can visualize the veins, see the blood flow, and actually see the clot or see that the vein doesn't compress properly, which indicates a clot is present.
Ultrasound. Okay. And what about the D-dimer blood test? How does that fit in?
D-dimer measures fragments of fibrin, which is part of a blood clot. So if you're forming or breaking down clots, D-dimer levels go up. It's useful mainly as a rule-out test in patients you think are low risk.
How so?
If a patient has low clinical suspicion for DVT and their D-dimer test is negative, you can be pretty confident they don't have a DVT. It helps avoid unnecessary imaging. But a positive D-dimer doesn't confirm a DVT
Why not?
because D-dimer can be elevated for many other reasons: infection, inflammation, recent surgery, pregnancy, cancer. So a positive result just means something's going on with clotting or breakdown, and you still need that ultrasound to confirm if it's a DVT.
Okay, so negative D-dimer in low-risk patient, likely no WT. Positive D-dimer need the ultrasound.
That's the gist, yeah.
All right, management and prevention. Preventing VTE is huge, especially in hospitals. What are the key preventative measures, the prophylaxis?
It starts at the basics. Patient education about risks, encouraging leg exercises even in bed, getting patients up and walking, early ambulation as soon as possible after surgery, keeping them well hydrated.
And the mechanical stuff.
Right, using graduated compression stockings, GCS, those tight TED hose and intermittent pneumatic compression devices, SCDs, those sleeves that inflate and deflate around the legs to squeeze blood out and prevent stasis, sometimes called venous foot pumps too.
Now, probably the single most critical safety point, if a DVT is suspected or confirmed, what should you absolutely not do?
This is life or death critical. Never massage the affected extremity, ever.
Why is that so dangerous?
Because rubbing or massaging the leg could potentially dislodge that clot, sending it embolizing up towards the lungs, causing a potentially fatal pulmonary embolism. Absolutely forbidden.
Okay, no massaging. Any other don'ts?
The sources also advise against continuous warm, moist soaks. While warmth might feel good, the increased circulation could theoretically also increase the risk of dislodgement. Stick to prescribed anticoagulants and rest.
And if, despite everything, a PE does happen, what are those sudden alarming symptoms we need to jump on immediately?
Sudden onset of sharp chest pain, severe shortness of breath, dyspnea, maybe coughing up blood, hemoptysis, rapid heart rate, intense anxiety, a feeling of impending doom. These signal a PE and require immediate emergency response. Constant vigilance for these is part of DVT care.
Okay, so the treatment for VTE is anticoagulation blood thinners. But these drugs carry a high risk of bleeding, so the monitoring and patient teaching have to be absolutely spot on. Let's start with the classic IV one, unfractionated heparin, UFH.
Right, UFH is usually for acute, rapid anticoagulation in the hospital. Given 5, often as a continuous infusion on a pump because its effect starts and stops quickly.
And how do we know if we're giving the right amount? How is it monitored?
We monitor UFH using a blood test called the Activated Partial Thromboplastin Time, or APTT. We're aiming for a specific therapeutic range.
What's that range usually?
Typically, the goal is an APTT that's 1.5 to 2.5 times the normal control value. So if the lab's normal APTT is, say, 30 seconds, we're aiming for an APTT between 45 and 75 seconds in the patient. This means the blood is thin enough to prevent clot growth, but hopefully not so thin it causes spontaneous bleeding.
Okay, 1.5 to 2.5 times normal. What's the critical panic value? When do you call the provider immediately?
The critical rescue alert is if the APTT gets too high. The source mentions greater than 70 seconds as a key threshold, though labs vary slightly. High 60s, 70s is the danger zone. An APTT that high means the patient's blood is too thin, huge risk for bleeding.
So 70 seconds, you stop the heparin, call the doctor.
Absolutely. Notify the provider immediately. The infusion will likely be stopped or the rate drastically reduced. And thankfully, there's an antidote if needed.
Which is?
Protamine sulfate. It works very quickly to reverse heparin's effects if serious bleeding occurs.
Good to know. Okay, moving to the long-term oral option. Warfarin, Coumadin. This one works differently, takes longer, right?
It does. Warfarin works by inhibiting the liver's use of vitamin K to make certain clotting factors. Because the body has existing clotting factors floating around, it takes time for warfarin to deplete them. So it takes about 3 to 4 days for warfarin to reach its full therapeutic effect.
Which is why you need that overlap, the bridging.
Exactly. If someone has an acute DVT or PE, you start them on fast-acting heparin, or LMWH, and warfarin at the same time. You continue the heparin for several days until the warfarin kicks in and gets the blood thin enough on its own. Then you stop the heparin. That's bridging.
Okay, makes sense. Warfarin isn't monitored by APTT. It uses the INR, right? International Normalized Ratio. What's the target range for that?
Correct. INR is the standard for warfarin. For most conditions like DVT or PE, the desired INR range is typically 2.0 to 3.0. For some higher risk situations like mechanical heart valves, the target might be higher, maybe 2.5 to 3.5, or even 3.0 to 4.0, but 2.0 to 3.0 is the common one.
And keeping it in that narrow range is crucial.
Absolutely critical. Below 2.0, you're not protected enough, risk of clotting. Significantly above 3.0 or 3.5, the risk of serious bleeding like a GI bleed or brain hemorrhage, goes way up. It's a tightrope walk.
Which brings us to the absolutely essential teaching point for warfarin, the diet interaction.
Yes, this is non-negotiable. Patients must understand the interaction with vitamin K. Since warfarin works by blocking vitamin K, eating large amounts of vitamin K can counteract the drug.
So what foods are high in vitamin K?
The big ones are dark green leafy vegetables, spinach, kale, collard greens, broccoli, Brussels sprouts, parsley, things like that.
So do patients need to avoid these foods completely?
Not necessarily avoid them completely, although some providers might suggest that for simplicity. The most important thing is consistency. If a patient normally eats a salad with spinach 3 times a week, they should keep doing that consistently. The warfarin dose can be adjusted to that stable intake.
So the problem is big changes in vitamin K intake.
Exactly. The problem is suddenly eating huge amounts of kale one week and none the next. That makes the INR swing wildly up and down, making it impossible to keep them therapeutic and safe. Consistency is the key message.
Consistency in vitamin K intake. Got it. What other general safety advice for warfarin patients?
Standard bleeding precautions. Watch for blood in urine or stool, easy bruising, nosebleeds that won't stop, petechiae, those little red dots. Teach them to use an electric razor, not a blade. Soft toothbrush. Avoid risky activities where they might get injured.
And inform other providers.
Definitely. Tell their dentist and the other doctors that they're on warfarin before any procedures. And like heparin, warfarin has an antidote if needed.
Which is?
Vitamin K itself can be given orally or IV to reverse the effects if the INR is dangerously high or there's major bleeding.
Okay. Lastly, briefly, there are the low molecular weight heparins, LMWHs, like enoxaparin Levinox, and the newer direct oral anticoagulants, DOACs.
Right. LMWHs are like a more predictable version of heparin, given by subcutaneous injection, often used for VTE prevention or even treatment at home. The DOACs drugs like dabigatran Bradaxa, rivaroxaban Xarelto, apixaban Eliquis have been a real game changer.
Why is that? What are the advantages?
Their big pluses are fixed dosing, usually once or twice a day. They generally have a lower risk of major bleeding compared to warfarin, and this is huge for patients. They typically do not require routine INR monitoring. No frequent blood tests. Makes life much simpler and safer for many people needing long-term anticoagulation.
Okay, our final segment looks at the long-term consequences when venous return isn't working well over time. This leads to chronic venous insufficiency, or CVI.
Exactly. CVI happens because of prolonged venous hypertension, high pressure in the veins, usually in the legs. Over time, this high pressure stretches the veins out and damages the tiny valves inside them.
The valves that normally stop blood from flowing backwards.
Right. When those valves fail, blood doesn't return to the heart efficiently. It pools or stagnates in the lower legs. This leads to edema, swelling, and eventually damages the surrounding tissues because even though arterial blood might be getting there okay, the waste products aren't getting cleared out properly due to the backup.
So, what are the telltale signs of CVI? How does it look different from acute DVT or PD?
You'll typically see persistent edema in the lower legs, often described as non-pitting or only pitting with difficulty. The really characteristic thing is skin changes, called stasis dermatitis. The skin around the ankles takes on this brownish or reddish-brown discoloration.
Why the color change?
It's from red blood cells leaking out of the high-pressure capillaries into the tissue. The iron pigment, hemosiderin, stains the skin over time.
Okay. Brown staining around the ankles, and this can lead to ulcers.
Yes, eventually this poor tissue health leads to venous stasis ulcers. These are typically located over the medial malleolus, the inner ankle bone. They tend to be large, shallow, moist, or weepy, with irregular borders. Different look and location than those painful arterial ulcers on the toes.
Got it. Inner ankle, moist, irregular borders. So interventions for CVI are all about fighting that pooling and pressure, right? Getting blood back up the leg.
Exactly. It's the opposite of PAD, where you might want the leg down for rest pain. Here, we need to counteract gravity. The two pillars are compression and elevation.
Let's talk compression first.
Compression is absolutely key, usually with graduated compression stockings, GCS, prescribed to provide the right amount of pressure. The teaching for putting these on is vital.
What's the right way?
Apply them first thing in the morning before getting out of bed when leg swelling is at its minimum. Smooth them on carefully, make sure there are no wrinkles, and never ever roll the tops down or bunch them up.
Why not roll them down?
Because that creates a tight band, like a tourniquet, which actually worsens venous return above that point. Defeats the whole purpose and can be harmful. Smooth application is crucial.
Okay, morning application, smooth them out. And elevation.
Yes, frequent elevation. Patients should elevate their legs so their feet are above the level of their heart. Just propping them on a stool isn't enough. Aim for at least 30 minutes at a time, maybe 3 to 4 times a day. Use gravity to help drain the legs.
Above the heart. Got it. Any activity advice?
Encourage walking and calf muscle exercises as muscle contraction helps pump blood back up. But they should avoid prolonged sitting or standing in one position, as that just lets blood pool. And definitely avoid crossing the legs, especially at the knees or ankles, as that kinks the veins.
Okay. Briefly, we also see varicose veins in this category. How are they different?
Varicose veins are more about the superficial veins becoming distended, enlarged, twisted, and visible under the skin. They can ache or feel heavy. While related to venous pressure, they don't necessarily imply the deep system valve failure seen in severe CVI with ulcers.
And management is similar.
Pretty similar principles, often called the 3 E's: elastic compression, stockings, exercise, walking, ankle flexion to pump the calves, and elevation. For more severe cosmetic cases, there are surgical or minimally invasive options like endovenous ablation. #tag outro.
Wow, we covered a lot of ground there. A really critical deep dive, highlighting that fundamental split between arterial issues, think perfusion problems, and venous issues, think clotting problems.
Absolutely. And for you listening, the key really is keeping those two pathways separate in your mind when thinking about assessment and care.
So let's synthesize. For arterial problems like PAD and atherosclerosis, the big risk is ischemia, tissue death, limb loss. Your focus should be on promoting blood flow to the tissues.
Right. Think statins, antiplatelets to keep things open.
Mhm.
Remember the no direct heat rule. Remember that dependent positioning can help relieve rest pain. Monitor those crucial 6 Ps for acute occlusion.
Okay. And then for venous problems like VTE and CVI, the main risks are clots traveling, embolism, and blood pooling, stasis, so the focus shifts completely.
Exactly. Here you're focused on preventing clots from forming or growing and getting blood back to the heart. Think anticoagulants, compression stockings, regular elevation, and that absolute safety rule: do not massage a leg with a suspected DVT.
And underpinning all of this is meticulous medication safety. Those teaching points are non-negotiable.
You absolutely have to drill those in. The INR target for warfarin and that critical vitamin K consistency teaching,
Hmm.
the ATTT danger zone for heparin, holding beta blockers for low heart rate or BP, and that potentially severe grapefruit interaction with statins and some CCBs. Nailing these protects your patients.
Definitely. Now, our sources pointed out something worrying. Hypertension and hyperlipidemia rates are rising and starting younger. The groundwork for serious vascular disease is being laid down earlier and earlier.
It really is. Atherosclerosis doesn't happen overnight. It's a decades-long process, often starting in young adulthood.
So, given that we have effective prevention tools like the DDAS-H diet, statins, reliable screening tests like ABI, BP checks, cholesterol panels, here's the final thought we want to leave you with.
If we know this trajectory starts decades before the heart attack or stroke happens, how can we as a healthcare system and as individuals really shift the focus? How can we leverage early screening and aggressive lifestyle and medical prevention in younger people to fundamentally change the course of vascular disease before symptoms ever appear, instead of just managing the crisis later on?
A really vital question for the future. Thank you for joining us for this deep dive. We hope this helps solidify these crucial concepts. We'll see you next time.